All right, so hello everybody. We are going to do the part one of your chapter 6 in your pharmacology book. It is anesthetics and narcotics, chapter 6, first part of PowerPoint lecture. So your nervous system is actually divided into two main systems. So you have your central nervous system and then you have your peripheral nervous system. So underneath your central nervous system, you have your brain and spinal cord. Under the peripheral nervous system are your nerves and your sensory receptors. So with the nervous system, you have an afferent and an efferent system. Your afferent system transmits the information from the central nervous system, or CNS, to the receptors, where the efferent system will send the information from the CNS to the body. Okay, there's different sensories in somatic, motor, and autonomic. So your somatic sensory, is the information that is received from your skin, your fascia, your joints, your skeletal muscles, ears, nose, tongue, and throat, or nose and throat. Your sensory information is received from the viscera. Your somatic motor is voluntary muscle movement. Okay, so if I want to lift my hand, that's voluntary. If I want to scratch my head, that's voluntary movement. Autonomic is what controls the organs and those functions or those movements which are not voluntary. So if you think about what would be considered not voluntary movement, think about your heart beating. That's muscle movement, but you're not physically sitting there telling your heart in your mind to go beat, beat, beat. Lungs, breathe, breathe in, breathe out, breathe in, breathe out. We don't think about those things because that's done automatically. Your nervous tissue, so you have chemical signals that is received on a cell body and the dendrites. That chemical signal is then converted to an electrical impulse or signal. It is then sent, it travels down the axon to the axon terminal, in which the axon terminal will release to the neurotransmitters, and that's how it spreads to the rest of the body. So if you are looking on slide 9, because this is where we're at here, you have the different neurotransmitters. So we have different neurotransmitters within our brain, within our central nervous system. And some of these neurotransmitters work within both the central nervous system and the peripheral nervous system, and some work in either or. So for acetylcholine, also known as ACH, this one works in both central nervous system and the peripheral nervous system. So the function of this neurotransmitter is it stimulates skeletal muscles, it inhibits the cardiac muscle, it can inhibit and excite the smooth muscles and glands. So when you think about acetylcholine, when you think about anticholinergic drugs, those are anti-acetylcholine. So they block the release of acetylcholine in certain areas of the body to stop that smooth muscle movement. So kind of put that into perspective, when we take anti-acetylcholine drugs for, let's say, spastic bladder, the acetylcholine neurotransmitter within our body is working overtime in our bladder. When we take a medication to prevent that from happening, it stops the bladder from accepting the signals and impulses from acetylcholine, the neurotransmitter, and it helps stop that spastic bladder. GABA only works in the central nervous system. This is the primary inhibitory neurotransmitter in the brain, and it can impact muscle tone. So too little, too much GABA in our system can impact muscle tone. Dopamine also only works within the central nervous system. It plays an inhibitory role, but it's important in cognition, motivation, behavior, and mood. So we have a lot of medications that are dopamine receptor specific to help increase dopamine. One of the things that they think causes Alzheimer's and in Parkinson's disease is a decrease or not enough production of dopamine. And so we have medications that are used to help increase those levels. Epinephrine, you've all heard about epinephrine. We have epinephrine and what we call EpiPens. Those are used for people that have anaphylactic allergies, so a bee sting. They would inject the epinephrine to prevent the anaphylactic reaction. But we also use epinephrine in our crash carts, in our cardiac crash carts. So if a patient is coding, their heart stopped, we can use an injection of epinephrine to restart the heart, hopefully. The effects of the epinephrine are in the thalamus, the hypothalamus, and also within the spinal cord. Norepinephrine works in both the central nervous system and the peripheral nervous system. It modulates the sympathetic part of the autonomic nervous system. Norepinephrine is also something that we use within our cardiac patients to help with that. Again, when you think autonomic, we're not telling our cardiac muscle or our heart to beat. And so we're using these type of medications more specifically in life-saving situations. Serotonin works only within the central nervous system. Its functions are related to sleep, appetite control, cognition, and mood. We know that we have some medications that are selective serotonin reuptake inhibitors. We use a lot of antidepressants to circle around serotonin. A lot of work that has been done, and that's something we'll cover in Chapter 7 as well, for patients that suffer from mood disorders and depression. It's a result of how much or how little serotonin neurotransmitters are being produced and reused within the body. Glutamate is also on the central nervous system. It plays an excitatory role within the system. It also promotes cognitive function, and it's actually the most common neurotransmitter in the brain. So the mechanism of action for neurotransmitters. Their response to various adrenergic receptors to both epinephrine and norepinephrine. So you can have alpha receptors. Alpha receptors will constrict blood vessels, and they're also used to help with decongestion. Beta-1 receptors increase not only the heart rate, but also the contractive force of the heart. Beta-2 receptors are responsible for the dilation of the bronchial tubes and the blood vessels. So for an example of a beta-2, when you have patients that have asthma and they use albuterol as a rescue inhaler, that is a beta-2 receptor drug. And the reason for that is because when they use the inhaler, that inhaler causes dilation or opening up of the bronchial tubes, so they're able to get that transition or that exchange of air for CO2. It helps them breathe better. So anesthetics, their role within therapy, so it inhibits pain or the conscious perception of pain. So general anesthetics provide a reversible, so not an irreversible, but a reversible loss of consciousness and perception of pain. So if any of you have ever had any type of surgery and they put you under, is what we call it as well, that is general anesthetics. So they have used the medications to put you into an unconscious state where you're not feeling or remembering any of the procedure that is taking place. Imagine, World War I and, all of the wars before that, Civil War, all of that, they were doing amputations in the middle of the field with no anesthetics. So you can imagine how much this has been quite a discovery for medical advancement. Local anesthetics are the opposite. So they don't provide a loss of consciousness. They just provide a local blocking, right, at the site of the transmission of the pain signal to the central nervous system from a specific site on the body. So if I tripped and fell and I needed stitches in my face, they're going to use a local anesthetic right in the spot that I need stitches. So that blocks that pain receptor, the signal being sent to my central nervous system when they start sticking the needle and thread in there to sew it up. But I'm awake. I'm just not feeling that specific site. How they determine the choice of anesthetics depends on a couple things, and it depends on the clinical need. Why do they need to have anesthetics? And then patient safety. So what is the best route? Not all patients are a candidate to be placed under general anesthetic. A lot of patients that have lung disease or trouble breathing, because in anesthetics they don't just use injectable medications, they also use gases. And if someone is already having trouble breathing, they're going to have a hard time exchanging that gas out once the surgery is over with the oxygen. So sometimes that's a little bit, it just depends on their situation. Anesthesiologists, I can tell you in my whole career in the hospital I worked at, they're generally not nice people, individuals. They work very hard. They have a lot of responsibility on their hands. They are the ones that are keeping you alive during surgery. So I could understand some of their personality traits when it comes to that. But anesthesiologists are doctors, and they oversee the administration of anesthesia during the surgery. So when you're in surgery, you're not just having the surgeon that's actually in there doing the work. You have an anesthesiologist that is monitoring you and administering the drugs to keep you unconscious during that time. General anesthesia action. So not only do the general anesthesias cause unconsciousness, they provide analgesia, which means relieving of pain. They relax your skeletal muscle system, and then it provides amnesia upon recovery. So it's not allowing you to remember what took place during the surgery. Okay. General anesthesia assessment. So during your time under, the anesthesiologist and their technician are monitoring your blood pressure. They're looking at your plasma volume. They're looking at your oxygen levels, your pulse respiratory rate, your pulse and your respiratory rate. They're looking at your tissue perforation and eventually urine output. Urine output is a good indication that our kidneys are functioning properly. Pre-anesthetic medicines or medications are typically narcotics that are given to alleviate pain and depress the respiratory center. The benzodiazepines, so things like Ativan, Valium, they're given to help provide sedation, also the amnesia, and also anti-anxiety effects. So most of the time if you've gone in, they're going to offer you, when you're in pre-op, and that's what we call going into the surgery room, that area is called pre-op. That's where they get you prepped for surgery. They're coming in, they're starting your IV line, you're getting into the gown, all of that situation. And usually the anesthesiologist will come in and offer you some sort of cocktail, happy cocktail they call it, or anti-anxiety cocktail. And that's because they know that patients start to get very anxious as that time is winding down for them to go into the operating room. And so they will use benzos or benzodiazepines, again, like Valium, diazepam, Versed. Versed's actually the most common. You can only get that in an injectable form of benzodiazepine to help alleviate that anxiety, because as you get anxious, your blood pressure is going to rise, your pulse is going to rise, your respirations are going to rise, and it's going to be harder to get you calmed down. So they're going to start that effect pretty early before you go into surgery. So part of anesthetics and having surgery is a risk of a condition called malignant hypothermia. This is a rare, but it's a very serious side effect of having anesthesia. So it's characterized by a sudden and rapid rise in body temperature with irregularities in both heart rhythm and breathing. It is a life-threatening condition which must be treated immediately, and the only medication that actually treats malignant hypothermia is called dantrolene, which is actually a skeletal muscle relaxant. So if you think about it, think about when you've had surgery and you've come into post-op. You've done pre-op, they got you all prepared for surgery, you go into the OR, you have your surgery, and then when you're done, you go into what they call the recovery room. We call it post-op. And during this time, you're having a nurse checking on you. They're giving you more pain medications, but they're also checking for your temperature. They're checking your blood pressure. They're checking your body temperature, because malignant hypothermia is what they're checking for. It's a very rare condition, but it is very serious if a patient starts to suffer from malignant hypothermia. In the hospital, we do what we call malignant hypothermia kits, and it has the dantrolene, it has all of the dosing and the prescribing informations within this kit, and they're kept inside the post-op area, so they have quick, easy access if they start to see that a patient is starting to have a sudden and rapid rise in their body temperature, any irregularities in their heart rhythm and their breathing. So the last slide here, we're going to go into maybe a couple slides. So inhalant anesthetics, those are the gases that I mentioned earlier. So they're stored in steel containers as either compressed gas or liquids. Patients will inhale these through the face mask. Our respiratory system excretes 80 to 90% of the dose once we're out and in the recovery. That's why it's dangerous for some patients that have certain lung conditions. Side effects of these inhalant drugs is a decrease in blood pressure, an increase in your fluid of your blood, a decrease in your renal function, which is another reason why they're monitoring your urine output, and then nausea and vomiting. So a lot of people think that they only get sick after surgery because of the amount of narcotics that they're being given. Usually that's the case, but some people are very hypersensitive to the gases as well, and that can cause the nausea and vomiting as well. So on slide 15, it starts to go through some of these inhalant gases. So we have nitrous oxide, we have the ethane, isoflurane, desflurane, which is suprane, ultane. So these here, you're going to actually, your assignment for this day is going to be completing a drug tree chart for your inhalant anesthetics. You're going to use your book. You can use the PowerPoint as well, slides 15 and 16. But when you're doing this, I want you to include both the brand and the generic name. And yes, these gases have both brand and generic names. So when you're filling in your tree chart, I want you to make sure that you're including both the brand and generic name. Now, to get those names into the little bubbles in the assignment itself, you're going to have to use a text box, and that's in the word function. So for each bubble, you're going to select create your own text box, and you're going to draw that within the circle, and that's going to allow you to type in both the brand and generic name of the drug. So if you have any questions on that, make sure you either call me or email me right away. So we're going to finish up here. That was slide 16. That's before we start heading into the injectable medication. So you will have 2 assignments due. You're going to have a recap of everything that we kind of covered here. So you're going to read in your chapter. I have those pages assigned, and then you're going to review your PowerPoint through slide 16, and then you're going to complete both assignments.